Hey, welcome to another episode of Talking with Docs. I'm Dr. Paul Zalzal.
I'm Dr. Brad Wiener.
And we have a guest today.
I'm Sandy Andrighetti.
Thank you, Dr. Andrighetti, for joining us. Dr. Andrighetti is an OB/GYN, obstetric and gynecologist specialist.
Yeah.
And what are you talking about today?
So today we have a bit of a provocative topic, and
Okay.
it's going to be cesarean birth at maternal request.
Okay.
Cesarean birth at maternal request, CBMR.
Yeah, that's how it's being coded. Yeah.
So let's start at the beginning.
Sure.
What are we talking? What does this mean?
So women, while we always recommend a vaginal birth,
Okay.
we think that is safe and
Yep.
we recommend it. It's becoming a request for women, and women have choice to have a cesarean birth as their mode of delivery.
Okay, break it down. Cesarean birth. What exactly does a cesarean birth mean?
So you can either deliver your baby vaginally, which would be the most traditional way,
Right.
or you can have a surgery. So typically there's a medical indication to have your surgery, or a fetal indication, either the baby or the mother. There's a reason why we'll recommend a surgery. We're surgeons.
Right.
You guys are surgeons.
Yep.
Yes.
As surgeons, we never recommend surgery unless we think there's no other reasonable alternative.
Last resort.
Last resort. Surgery is always fraught with risk, right?
Right.
So we always recommend, and we think vaginal birth is safe. All societies do. But there is room for a discussion with some patients who want choice.
Okay. And this is outside of the medical reasons like risk to the mom, risk to the baby, the placenta's in the wrong position, or whatever.
Exactly.
Okay.
So there's not a fetal concern, there's not a maternal concern. They just want to have a cesarean section
Right.
for the birth of their child.
So
Okay.
cesarean section where an incision is made and the baby is extracted.
Surgical.
And
Yeah,
surgically.
exactly. So you have an anesthetist, it's an operation.
Okay.
So what would be the main reasons that someone would come to you and say, listen, I'm interested in this without any specific medical indication?
Yeah, so they've reviewed the risks and benefits and they think that it aligns more with their thinking.
Okay.
So a lot of times women will have had previous birth traumas. So their first delivery was a traumatic experience or had a complication that they don't want to encounter again. So they'd rather just avoid all that and go straight to a cesarean section.
And when you say trauma, you're meaning like emotional or physical pain. I'm sure that's part of it, as well as maybe even an injury of some sort.
So so pelvic floor injury is the biggest one. So
Right.
people have either want to avoid all pelvic floor injury. They know they're only going to have one child.
Yeah.
So they think, well, I'm only going to have one and be done. So I don't want to have any pelvic floor injury. We
Right.
know there's an increased risk of pelvic floor injury down the road. And you can have stress incontinence even with having a cesarean section,
Right.
but it's going to be higher when you
How common is this, pelvic floor injuries after vaginal delivery?
So it depends. We think it's the same if you have an unassisted, and what that means is no vacuum, no forceps.
Okay.
So if you need a vacuum or forceps, your risk of pelvic floor injury is higher than, is pretty high.
We use
does
a
that
hammer
look
and a saw, you use a vacuum and forceps.
Yeah.
The tools
More
are
civilized.
wacky tools.
So what are some of these, what are the manifestations of pelvic floor injuries down the road? So what can happen clinically or realistically to you after the vaginal birth down the road?
So we think it's mostly assisted vaginal birth.
In
So
the
just so
assisted
that we're
vaginal.
clear, the studies think it's mostly assisted vaginal birth. You can have an increased risk of stress incontinence over a cesarean section.
Okay.
So that means when you jump or exercise, you can lose urine.
Right.
You can have an increased risk of prolapse, which
Okay.
means your pelvic organs are sort of falling below their normal place in the body. So they can even come outside your body, but that can happen even with a C-section,
Okay.
but certainly more common with a vaginal birth. And then the biggest one that worries some women is anal sphincter injury. So that's the structures that keep us continent of stool and gas.
Right.
Because
Okay.
that's a little less socially acceptable in our society and can be very problematic for women and often need more surgery.
Okay, and those consequences you will see many years after.
Typically,
Yeah.
we know, well, some will still have them at 1 year.
Okay.
And if you have them at 1 year after your delivery, you're going to have them,
Okay.
they'll continue.
Okay.
It's
And
unlikely to recover.
Many of those are treatable.
Yes, yeah.
There's treatment
treatable with
options.
further surgery
Further
and, or, flaps and advancement flaps. And that's so.
Okay.
It's a big deal.
It's a big deal.
Yeah.
Yeah.
So that's the thinking that people approach this with, and they think, well, maybe I don't want to have that. I'd rather have a cesarean section.
Yeah, and some people mothers would rather take on maternal risks of the surgery than
Right.
to expose their child to any risks of labor.
Okay.
So let's talk about that. So let's talk about a C-section. Now let's talk about the risks that are specifically associated with having a C-section, or why maybe your OBGYN is telling you, maybe we should consider vaginal delivery instead. So what are the risks of C-section?
Yeah, so there's the immediate risk. So we know you have an increased risk of bleeding, for sure, during the surgery. There's an increased risk of infection, both at the incision. You guys see that all the time.
Yeah, similar infection.
Yeah, long-term risk of hernia. So especially if you have multiple C-sections. There's, believe it or not, a very catastrophic increased risk in maternal mortality, although thankfully that is so rare, but it is slightly increased.
So it's an increased risk of a catastrophic event, not a catastrophic increase in the event.
Correct,
so tiny increased risk of something really bad.
That doesn't happen, thankfully, hardly ever at all.
Blood clots?
Increased risk,
Increased risk. Longer stay in the hospital?
Increased risk, yes.
Typically how long?
Anywhere from 1 to 3 days.
And if you had a standard vaginal birth that was uncomplicated?
Less than, like 2 days, 1 to 2 days, typically. But it all depends on how the baby is doing. There's risks to the baby as well. So if we're going to do an elective C-section, the recommendation is we have to do it at 39 weeks or longer. And the reason is babies will have more struggle with breathing. So when they come through the vaginal canal, they get a squeeze. I say they spend a little extra time in the spin cycle, whereas they're not getting that when you have a cesarean section. So there's an increase in neonatal morbidity or complications with breathing. Some people think there's increased risk with the exposure to the vaginal tissues of the microbes of the vaginal tissues, although that's not
controversial. That increased risk to infections, right?
No, improved.
Oh, no, I mean if you would do vaginal delivery.
So there's both angles.
Protective.
There's both angles. So there's the STI angle. So anyone who's had previous herpes or was worried about transmission. But then there's the protective angle
of the microbiome being exposed.
Yeah. So there's
that you lose with a C-section is what I mean.
Correct. Yeah. And then subsequent pregnancies can be really complicated when you've had one cesarean section. That's our biggest fear as obstetricians, is that the placenta invades into where that cut is inside in the uterus.
So that makes some subsequent pregnancies risk of complications.
Yeah, exactly. It's called placenta accreta, where it invades. It doesn't have that nice, doesn't divide nicely as it goes in.
So high risk to the mom, high risk to the baby.
And subsequent pregnancies, for sure.
And of course, scar, right? There's a scar. You're going to have a scar with a surgical procedure, and some people heal scars with keloids, so you could have a scar that you might consider unsightly.
Right, so that's the cosmetic scar, and then there's the internal scar. So we know that people who've had repeat cesarean sections can have problems with bleeding in the future. They can have some more painful periods going forward, and their uterus can in fact rupture if they choose to either deliver vaginally for the subsequent pregnancy or even before they get to their C-section.
Which is also very rare but very dangerous.
Very rare, but very dangerous.
And another thing I would say after surgery is that you have to take it easy, right? You're not supposed to lift things over approximately 10 pounds, I think is what I read for.
Well, yeah, I mean, that's debatable. Same thing with the driving.
Driving, I didn't know that.
Yeah, so some guidelines will say you can only drive until you can safely stop the vehicle with, on your own, and you're not on narcotics, right?
That's so another.
We have similar guidelines after surgery. So with all those risks of a cesarean section, that is still being, now you're saying some people are choosing to do that over the vaginal.
The only other one that sometimes people will discuss with us is the decreased risk of late stillbirth. So we know if you're going to have your cesarean section at 39 weeks, you avoid those, which is again a rare but catastrophic event, that your baby is out of the uterus, in your arms, 39 weeks, done. And people feel comfortable about that. So if you have a patient who uses that as an indication, we have to counsel them and say, maybe we can do an induction of labor so we can address that fear. So you want to always have a good amount of time to talk to your patient and say, what's driving this? And how can we make that better without exposing you to increased risk? So induction of labor, if it's a social reason, induction of labor, if it's fear of stillbirth, because they say, well, my friend went to 40 weeks, lost the baby. So you need to know what's really driving
And if it's based in fact or fiction, then it's real to them, but you want to dispel some of these myths maybe for some of these people saying, hey, listen, just so you know, this thing you're worried about maybe isn't really as big of a concern as you think.
Or this thing you're worried about, maybe we can approach it and help you solve that problem. Or how can we help because it's shared decision making, right? So how can we help address that issue in a safer, perhaps less complicated manner?
It's a scheduling thing.
Yeah.
I got a golf game schedule. I got to get this done. So can you give us some numbers?
Super Bowl.
Yeah.
That's another one I get a
Is it
lot.
really? The
Yeah,
Super Bowl?
Seriously.
Seems like a bad reason. Okay. Okay, so incidents of say
what's the numbers?
what's the incidence of like emergency C-section versus maternal request?
So in Canada, and probably close in the United States, and Australia, New Zealand, it's anywhere from 30 to 35% of births are cesarean section. It is the most commonly
Wow.
done
1 in 3.
operation in Canada.
Right.
Wow. Okay.
Yeah, request is still, it's pretty flat. It's about 4% or
Okay.
less. In the US, they're reporting 2 to 3%. Problem is the coding is difficult.
Wait. 4% of 4% of what? That's people requesting it by choice.
Correct.
Okay.
As opposed to needing it.
Right,
As
so not a
opposed to-
maternal need.
Not a maternal need, and you get about 4%.
People walking in the
saying
door
that,
and
okay.
saying, I want to have a
Okay.
cesarean birth by request
Okay.
in Canada.
So that's 4% of the births.
Correct.
Okay. I wonder what percent of the 30% that are being done.
We don't know because we
Yeah.
have difficulty with coding.
Right.
Yeah, I've been looking at that,
to
and
tease
it's
it
difficult to tease it out. Exactly.
But yeah, we talked before, it's been on the rise since the 70s, and
Right.
the WHO has a specific target. We talked about this as well, is that the societies that the WHO covers are all very variable.
Right.
So a 10 to 15% cesarean section rate is not a realistic goal, and the main things that have changed since the 70s, you had mentioned before, is that the age of our patients is bigger, some of their comorbid diseases, including elevated BMIs, is higher,
Right.
And a bunch of other things like
Diabetes, hypertension,
Right.
all those factors.
that. Comorbidity.
Correct.
And it must vary quite widely geographically.
Exactly,
the
right?
rates.
So the BMI average in Canada is far different than the BMI, for example, in New Zealand or Australia.
Right.
Yeah.
Yeah, and even
And the US.
And so therefore the number of cesarean sections or the percentage of births that are cesarean section varies geographically
Yeah.
quite widely.
Yeah, exactly.
Interesting.
Are we the highest here? Canada, US, New Zealand, that kind of thing?
For cesarean section?
Yeah.
It's a good question. I read Australia is getting up there.
Okay.
And then certain countries, because of the healthcare system, people, we don't discriminate cost or fee. We're a universal
Right.
healthcare. So,
yes.
If you had to pay for it, maybe you wouldn't choose it.
or if you're going to pay for something, you're going to choose what you want.
Right.
That's complicated.
Interesting.
Yeah, it gets complicated.
All right.
So the take-home message for maternal request is: listen, if this is something you're thinking about, or you and your family are thinking about, have a conversation.
Yeah.
First with your family doctor, and then with your OBGYN to say, hey,
OBGYN.
here's what I'm concerned about. What are my choices? What's best for me? What's best for my baby?
Yeah, and it merits a long consultation.
And try to keep an open mind, probably
Yeah,
too.
exactly.
And I'm sure people come in, no, absolutely, I'm getting this.
And some obstetricians are absolutely no, you're not getting this.
Oh,
or
really?
other healthcare providers. Yeah.
Yeah,
So
that's
if your
tricky.
provider doesn't ethically or professionally feel they can go ahead with that, our guidance is that person needs to refer you on to someone else.
Different OB.
Oh, okay. And so what do you think? What's your feeling? Do you dissuade people? Do you persuade people? Do you?
I have a long counseling aid that I go through with them, and I go through every risk and benefit. Usually it takes about 30 to 35 minutes. Sometimes it's more than one counseling session.
Yeah.
And if the patient understands and wishes, then I support my patient's wishes.
That's a good way to be. For all of us, right?
Yeah.
That's those that we took,
Yeah, it's
right?
all shared decision making, right? We're a team.
Yeah.
So,
Wow.
love
There
it.
you go. That's
right.
something I did not know much about before this. Thank you very much.
you're
There
very
you go.
welcome.
If you have experience with this, please leave a comment. It will be very useful to other viewers as they look through the comments to help make their decision. And if you like this video, please like and subscribe to our channel.
And remember, you are in charge of your own health.
And thanks, Dr. Andrew Getty, for
Yeah,
joining us
pleasure.
today.
Thanks for
Thank
having me.
you.
We'll see you next time.